Good afternoon, everyone. Thank you for attending the NEST Forum. This is a test case session titled The Feasibility of Using Real-World Data in the Evaluation of Cardiac Ablation Catheters. And I'm going to take a brief moment to introduce the very important folks of this research project. I am Keonde Irvin. I am a NEST research project manager. Also on this call, we have Dr. Paul Coughlin, who is the Vice President and Global Head of Medical Device Epidemiology and Real-World Data Sciences at Johnson & Johnson. We have Dr. Joe Drozda, Director of Outcomes Research at Mercy. We have Mark Feldman, the Assistant Director, Cardiac Ablation, Mapping and Imaging Devices Team, Center of Devices and Radiological Health at the FDA. And then we also have Dr. Shuming Zhang, Director of Regulatory Real-World Evidence and Epidemiology Medical Devices at Johnson & Johnson. For my role in this presentation is to really give a brief overview or a synopsis of the test case and the relevance to the ecosystem, as well as its importance to NEST. And this test case uses the real-world data source is the electronic health records. It was a retrospective study. The project duration was roughly around 8 months, and as the title indicates, the disease area is cardiology, and this is involving a Class 3 device, cardiac ablation catheters. And one important note is this test case falls under the MEDUFA priority. And for this test case, there are a few important things to note as far as relevance, and then there's also important things to outline that NEST played a role in. So the criteria for selecting this test case, like I stated, is aligned with the MEDUFA 4 priority, which places importance of research of medical devices that exist in the pre-market approval PMA or 510K space. And specifically, health record data on medical device performance has the potential for being a rich source of information that can support evidence generation for devices that can provide a benefit for patients. And as far as the importance and the relevance to the ecosystem as a whole and NEST, this test case truly assessed the reliability and the validity of data capture on Class 3 surgical devices to study the safety and effectiveness outcomes surrounding an indication for expansion. And there were kind of 3 main focal points. One was creating a management and reporting structure to keep the project focused on task, and also while being flexible, the team was able to meet deliverables in a timely fashion. And another important role from NEST was facilitating the free flow of summary data and metadata between all the participating collaborators and the sponsor, Johnson & Johnson, and really to ensure that the research questions that were originally proposed in the submission were aligned with the clinical questions that are essentially necessary for those regulatory decisions. And one final point to mention with NEST's role is to coordinate that very important piece, the engagement between the project team as well as the FDA, and to kind of start that dialogue with the test case and the use of real-world evidence in regulatory purposes. And with that, I will go ahead and turn it over to the principal investigator, Dr. Joe Drozda.
Thank you, Keonde. Next slide, please. As Keonde mentioned, we performed a test case here assessing the feasibility of using electronic health record and other data for evaluating, in this case, ablation catheters to treat persistent atrial fibrillation and ventricular tachycardia. Next slide. Dr. Paul Coughlin will go through the rationale for the test case, and we'll also discuss the technology of interest and study design. Dr. Zhang, who will then discuss study processes, and then the findings from the study, and go over some key points of our experience. then we'll conclude with Paul going over the next steps in this work, because as you might guess from the title, a feasibility study, this is preparatory to a more definitive study later. Paul?
Thank you, Dr. Drozda. Good afternoon, and it's a pleasure to share with you the work that we've been doing now. It's almost 2.5 years in collaboration with Dr. Drozda and investigators from Mayo and Yale and Mercy and J&J. So the original reason for why we proposed this test case is that the FDA CDRH has cleared label extensions for medical devices using registry-based real-world evidence. Registries are resource intensive, they're slow to accrue subjects, they may have small numbers or high dropout rates, may only include skilled operators, and exist for a fraction of devices. They also have many advantages, but these are some of the disadvantages. So very large EHR and claims databases may address registry limitations. There's a great potential for EHR and claims data to provide insights on safety and performance of devices as used in clinical practice. But it is unknown if EHR can accurately ascertain unique device used, and also can it also measure study endpoints. So we propose this NEST test case to assess the feasibility of using EHR data for label expansion for PMA pathway devices. The other considerations in our proposal was that NEST provides an opportunity for J&J research teams to collaborate with FDA reviewers and researchers at leading healthcare systems in developing EHR real-world evidence to assess safety and performance of devices, and thereby build the ecosystem of real-world evidence in support of the benefit of patients, regulators, providers, and healthcare systems. So as we see it, this feasibility work lays the foundation for using EHR real-world evidence to support regulatory decisions. A little bit about the cardiac ablation procedure. So the top left shows a normal sinus rhythm in the heart. However, a condition that often develops is chaotic muscle fiber activation, leading to these asynchronous signals for the cardiac muscle to contract. The one solution that has been developed for this, in addition to medication, is a procedure using a catheter that is passed from the inguinal vein in the inguinal region into the one atrium and the next atrium, and then it's used to ablate certain areas of the heart, of the atrial muscle, where asynchronous signals are being generated, particularly around the pulmonary vein. And in order to do this, because the catheters that we'll be talking about today use heat from radio frequency, it's important that there's good cooling. So usually, if the tissue is flat, there's good cooling from blood flow, which then leads to optimal power delivery into the muscle tissue to ensure that a surface ablation can be made that really stops the asynchronous muscle signal from creating chaotic muscle contractions in the heart. However, in certain types of tissue where there may be pockets or valleys, there may be lack of cooling, and then when the heat is applied for the ablation, it creates the potential for a clot or coagulum, and therefore limits the ability of the electrophysiologist who's doing the procedure to deliver the power that's needed to create the isolation of the asynchronous muscle tissue. Next, please. So the evolution of the technology was originally the original ThermoCool or Navistar catheter was intended for cardiac ablation, and it had 6 holes for irrigation to cool the tissue around the catheter. Then a smart touch function was added, and this allowed the feedback on how much pressure was being applied by the electrophysiologist with the catheter in the atrium, so that the depth of the ablation could be monitored. The next technology was the surround flow, which improves the cooling during ablation by adding 56 holes rather than 6 holes. And then the 2 of these were combined into the STSF, which has both the improved pressure sensing and the cooling during ablation, and has 56 holes for irrigation. So the surround flow catheter has no labeled indication for persistent AFib. And persistent AFib is initial atrial fibrillation that starts as paroxysmal, which is generally intermittent. And the catheters all the catheters are approved for paroxysmal atrial fibrillation. But the more advanced stage, more chronic stage of atrial fibrillation, the persistent atrial fibrillation, none of these catheters currently have a labeled indication. However, the STSF for the program had a clinical trial for a label extension for persistent AFib, and the results were very positive, and so there's reasonable expectation that it may be approved for persistent AFib in the next short period of time. So the idea is to compare the slightly earlier technology that doesn't have a labeled indication for persistent AFib with the latest technology that has the label expansion for persistent AFib. However, we also plan to compare against antiarrhythmic drugs that are indicated, that it's the standard of care for persistent AFib and has been for many years. This is for persistent atrial fibrillation, and our next comparison is for ventricular tachycardia. Next slide, please. So again, for ventricular tachycardia, the two catheters that have the 6-hole irrigation, that's the lesser irrigation, do have a labeled indication for VT and have been used for at least since 2006 for ischemic VT ablation. That's particularly for people who've had heart attacks, and then after heart attacks there can be damage to the heart muscle, leading to irregular heart muscle beating, and ablation of the heart muscle in the ventriculum can help to create more of a harmonious and regular heart rhythm. However, the newer technology that has the better cooling doesn't have a label indication for VT. So our planned study comparison is to compare the newer catheters that have the better cooling system with the older catheters that don't have the cooling system but have a label for VT. So what are the elements, the key elements that need to be measured for valid study? Well, the first one is, do we have an adequate sample size within the network collaborator databases? It's also important to identify specific medical devices, particularly if we're comparing different generations of ThermoCool catheters. Can we accurately capture the newer generation versus the older generation? Can we accurately capture study endpoints for safety and effectiveness using the ICD-9 and ICD-10 diagnosis and procedure codes? And some of the questions we faced are, what are the positive predictive value of the codes for the endpoints? Can we build algorithms from the codes? If the codes themselves don't have good positive predictive value but not fantastic, can we improve that positive predictive value by putting together different types of codes, or looking at their timing relative to the event, or their setting? Was it in a hospital or out ER setting, emergency room setting? Were they the primary diagnosis or secondary diagnosis? And can we thereby improve classification by looking at some of these algorithms? Another factor is, how do we identify the cohorts if we're differentiating between paroxysmal and persistent AFib, or between ischemic and non-ischemic ventricular tachycardia? Can we accurately differentiate between these populations so we can create the study cohort and the comparator cohort? And then the question is also, what do we compare to? And can those comparison cohorts be identified? The other factor for these type of studies is control for confounders. And are the covariates needed to adjust for the differences in study and comparators available? And can we adequately adjust for differences in those covariates through propensity score stratification or other types of covariate adjustment procedures? And then, do we have adequate follow-up over 6 months or 1 year to ensure that our loss to follow-up is not too high to be a substantial threat to validity? So I'll now turn it over to Dr. Jang, who will talk about the endpoints that we use for the study.
Thank you, Paul. With respect to these real-world data studies outcomes for persistent AFib, for effectiveness outcomes, we are considering composite endpoint at 6 months, including rehospitalization for AFib, cardioversion for AFib, rehospitalization for heart failure, repeat ablation for AFib for comparison with ST-SF catheters, not with anti-arrhythmia drugs. For safety outcomes, we are considering a composite of 15 adverse events occurring within 7 days post the procedure, up to 3 months for pulmonary vein stenosis, atrial, esophageal fistula. For ventricular tachycardia, for effective outcome, we are considering composite endpoint, including rehospitalization for VT, rehospitalization for heart failure, repeat ablation for VT. For safety outcome, we are considering composite of 13 adverse events within 7 days post the procedure. The feasibility study design had several components, including defining data elements, identifying device use, abstracting device data, identifying patient populations, and then evaluating the performance codes and the algorithm used for identifying data elements. We have formed a collaborative cross-institutional team to execute the study. Team members have strong expertise in epidemiology, real-world data science, cardiology, electrophysiology, regulatory affairs, and bioinformatics, and experience in conducting distributed data network studies, such as the PICONET and Sentinel initiative, and provide multidisciplinary input. I'm going to turn over to Dr. Joe Drozda to discuss study findings. Joe?
Thanks, Shumeen. So what are the findings of our study? And remember, as we go through this, this was a feasibility study. We weren't doing a label expansion study. So our findings relate to our ability to do such a study. So first of all, we had to identify the devices of interest, the ablation catheters, and they had to be identified uniquely enough that we could differentiate among the various catheter types. The way we went about that was to use unique device identifiers required by the FDA on all medical devices currently. And what we found out in our efforts to identify these devices, that at the 3 different network collaborators, Mercy, Mayo, and Yale, that unique device identifiers are captured, but a little bit differently at each site. At Mercy, we do use point-of-care capture in the cath labs, or scanning as the devices are used. And at times, though, we had to use charge codes because we didn't have the barcode scanning system in place. So we had a little bit of a different methodology at different points in this study. And we were able to link the UDI to the patient in which the device was used in the electronic health record. Mayo Clinic has a sophisticated supply chain database, and they do capture UDI through barcode scanning and include it in that supply chain database, which they can then link again to the patient in the electronic health record. Yale uses a different type of inventory management system that does capture UDI, and they were able then to also link it to their electronic health record data and to the patient in the American College of Cardiology's NCDR atrial fibrillation ablation registry. So each of us were, systems were able to capture the data, but in different ways. And I think this is a key learning for research in every medical device type, where we're bringing together different health systems. We're going to find different ways of getting to the same end. The next thing we had to do was to actually identify the populations of interest, the atrial fibrillation and ventricular tachycardia patients, and identify them by the various subtypes of those arrhythmias. We used ICD-9 and ICD-10 CM diagnosis codes and SNOMED CT for capturing those data from discrete electronic health record fields. I think what we want to introduce here is the population of computable phenotypes. In other words, to try to find a patient who suffers from atrial fibrillation, but using computerized codes such that we can pull the data from discrete fields and not have to search text for that information. So this is what we found in terms of the numbers of the various catheters of interest that were used at the 3 health systems. This was a key finding in order to determine whether or not a study was actually feasible. Was our sample size big enough? So you can see we were able to separate our patient populations out in atrial fibrillation by paroxysmal and persistent, and in ventricular tachycardia by ischemic ventricular tachycardia, in other words, following a heart attack, or non-ischemic ventricular tachycardia. We were then able to separate out each of those subpopulations with respect to the types of ablation catheters used. The STSF catheter, the ST catheter, and an older catheter that we intended to use for comparison called Navistar, again, a Johnson & Johnson product. So you can see we have some pretty large numbers in terms of atrial fibrillation catheters, 791 STSF and for paroxysmal atrial fib, and 1,098 for ST. Some pretty good numbers for persistent AFib, and significantly smaller numbers in the ventricular tachycardia area. Now, we still felt that we had enough numbers in both ischemic and VTAC and persistent atrial fibrillation to proceed with a study. And now, how about the outcomes of interest when we're looking for adverse events following an ablation? Some key ones are acute heart failure, ischemic stroke, arrhythmia hospitalization, and cardiac tamponade, or compromise of the heart due to bleeding into the space between the heart and the pericardium. So that's a very key finding in safety following a cardiac ablation. What we did was we again devised computable phenotypes for these 4 adverse events, and then we had our clinicians perform a chart review to determine positive predictive value of each. And what we found was that we did really well with our coding and coding algorithms for acute heart failure and tamponade with 96 to 100% identification, but not as well in ischemic stroke and arrhythmia hospitalization, where we were down in the 56 to 63% range. There are a number of reasons why our initial attempt at doing coding and coding algorithms for these for ischemic stroke and arrhythmia hospitalization were not what we would like them to be. But I think the primary one was that those codes are often used when a patient is admitted to a hospital, or even as he or she continues to go through outpatient care. They are used as a substitute for history of. So once you've had an ischemic stroke, that code tends to continue to be used for all subsequent encounters, making it a little less accurate at the time that we're interested in counting it. Now, as Paul mentioned, a key finding that we were looking for with respect to feasibility of doing a study was completeness of follow-up over the year following the procedure. Now, when we talk about follow-up in real-world data, what we're saying is that we're looking for patients who have encounters within the health system that would indicate they're continuing to get their ongoing care in that health system. So things like hospitalizations, office visits, etc. So computable codes for each of those kinds of events. And how many patients, for instance, had a code occurring within 30 days of the ablation, or within 6 months, or within 1 year, and then what percentage of patients were actually captured at those individual timeframes. And as you can see here, we had one health system that had a fairly good follow-up out to 1 year of 66%, and the second one that did not, with the follow-up falling to 4% at 1 year. The reason for the discrepancy, most likely, is that the hospital with the better follow-up actually provided primary care for most of the patients that received ablation. The second hospital with less follow-up was a tertiary care, quaternary care referral center with that was not providing ongoing primary care for the patients that received ablations. A key, I think, learning for, again, for many medical devices. So what's been our experience so far? What are the kinds of findings and learnings have we gleaned from this effort? Well, first of all, we were very pleased that the individual investigators involved from the various network collaborators and from Johnson & Johnson turned out to be very collaborative and quite skilled with a lot of experience in doing these sorts of studies, including data network studies at PCORNet and Sentinel. Secondly, we also discovered, and we probably knew all along, that the multidisciplinary approach was critical to doing something this complex, including epidemiologists, clinicians, regulatory affairs, informatics. So we needed the whole team to accomplish this. Thirdly, the unique device identifiers that are available and can be used in multiple health systems, but there are different approaches, as we illustrated earlier, they get you to the same result. Another learning, I guess, and we should have expected this, is that there were growing pains in the contracting process between the Nest Coordinating Center and the network collaborators. Remember, this is the first time this had ever been done. So we were all plowing new ground, and we sort of anticipated these kinds of hiccups. They did lead to some contracting delays, but I think we've plowed the ground and it'll make things a lot easier going forward. And finally, I think it's the learning. These NEST test cases have provided great practical opportunities for everyone involved to deepen their understanding of real-world data sources and including the FDA. You really can't understand what's going on with real-world data unless you actually get your fingers in it and get dirty. Paul?
So what are our next steps with this test case? Well, we identified a number of challenges that need resolution. One is in defining persistent atrial fibrillation. And there are often multiple diagnosis codes associated with the same visit. And so what needs to be done is to develop algorithms using multiple codes or validating against a registry. Fortunately, in the Mayo Clinic, we have a registry that we can do validation of the codes against. Or at Mercy, developing natural language processing tools to improve the accuracy of the diagnostic codes. We also need to continue the validation of the primary real-world data study outcomes and also see if we can develop algorithms to improve the accuracy of identification of some of those outcomes. As we saw, as Dr. Drozda showed, some of the follow-up varies by healthcare system. So that either means, it appears that patients may not return to tertiary care hospitals for non-elective hospitalizations out to 1 year after the procedure. So that leads us to either not including those systems in the study, or alternatively, trying to find ways in algorithms in which we can better identify which patients are not just coming in for the surgery and will be leaving soon, but are really going to be staying in that healthcare system for longer periods of time and therefore have better long-term follow-up. We also have had discussions with FDA about the data elements, but there's still substantial work that needs to be done to understand whether FDA staff will accept these study components, such as the primary real-world data outcomes, which may be different from those in the clinical trials. For example, we propose endpoints of rehospitalization, cardioversion, or repeat ablations. What's typically used in the clinical trials are Holter monitor, ECG, and ICD measurements, which we don't find routinely in EHR data. So will these real-world evidence endpoints be considered clinical outcomes that really measure what these clinical measures are intended to predict? And will the comparator groups be considered relevant? And from a statistical perspective, will the adjustment for confounders by propensity score stratification procedures be acceptable? So our next steps then, next slide please, are, so we've identified that we have good positive predictive value of our endpoints. We can identify devices. We have a decent sample size. In some healthcare systems, we have good 1 year or 6 month or 1 year follow-up. So based on this significant progress in characterizing the validity of the EHR databases of Mercy, Mayo Clinic, and Yale for label extension study, and also because this NEST case was one of the first to complete of the 21 NEST cases, I think it may have been the first one, NEST granted us additional funding to continue to a phase 2 study. The goal of the phase 2 study is to translate the feasibility study advances to actual label change study, and that'll be submitted to the CDRH division once the study is completed. So that we don't make all this advances in understanding the feasibility, but don't actually get to then take it the next step to see if it can go, if it can be acceptable as a label change study. And the 2 label extensions that will be conducted are for ventricular tachycardia, to compare the newer irrigation technology catheters versus the early irrigation technology catheters that have a label for VT. And for persistent atrial fibrillation, to compare the earlier technology irrigation catheter to either the newer irrigation catheter that may have a label for persistent AFib from a clinical trial, if that label extension based on the clinical trial data is successful, and also to antiarrhythmic drugs that are currently labeled and approved for treating persistent atrial fibrillation. Thanks for that. I'll now turn it over to Dr. Feldman from FDA, who will make some comments and observations. Thank you.
Thank you to the TC7 pilot team. I'm going to wrap things up this session with a quick FDA perspective. I'm Mark Feldman, Assistant Director of the Cardiac Ablation Mapping and Imaging Team in FDA's Office of Cardiovascular Devices. Least burdensome provisions are a fundamental principle of FDA's approach to make regulatory decisions, with more focus on use of real-world evidence in recent years. In short, FDA's policy is to accept the minimal amount of information necessary to address the regulatory questions. You can reference the FDA guidance document on this slide to learn more about least burdensome provisions, and you'll notice that it was updated in 2019. Use of real-world evidence is an economic way to gather evidence to support regulatory submissions. FDA issued a guidance document in 2017 stressing that the characteristics of real-world evidence are critical, and also clarified that the evidence bar is not being lowered with the use of real-world evidence. FDA's support of MDIC and NEST is a great example of FDA not just agreeing that real-world evidence is, can be accepted, but also actively looking to facilitate and leverage the use of real-world evidence in regulatory submissions. Real-world evidence can be leveraged in regulatory submissions in different parts of the total product lifecycle. I listed some examples on this slide for pre-market, surveillance, and post-market applications with the use of real-world evidence. I personally have seen increased use of real-world evidence in each of these areas for cardiac devices and specifically for cardiac ablation technology. The reason why I've seen these increases for cardiac ablation is that real-world evidence is particularly well suited for devices intended to treat cardiac arrhythmias. Ablation catheter development is a very active space with hundreds of thousands of cases performed annually worldwide. Also, ablation catheters are sometimes used for non-labeled arrhythmias as practice of medicine, as you've seen. In addition, patients treated with catheter ablation get routine long-term follow-up that, if collected properly, may be leveraged for regulatory purposes. All the boxes are checked for the potential to use real-world data for this application. A critical factor, and one that's not easy, is that the available electronic health records and claims data includes key data that is needed to support regulatory submission. I'll conclude with some advice for those thinking to leverage real-world evidence for their device. First, you should identify the FDA staff who review your device and engage them early. An informational pre-sub is a great way to make that introduction with your team and your technology and what you plan to do. Second, you should know everything about the available content of your data sources, but do not analyze the data prior to discussing with FDA, which could bias the analysis. Most importantly, you should use the pre-submission process to your advantage to develop and get concurrence for your analysis plan and endpoints before you analyze the data or formally submit your regulatory submission. Thank you very much, and now we'll take questions from the audience. Please submit your questions through the Q&A icon at the bottom of your screen.